for the Lagos State Health Service Commission at the Pediatrics Department of various hospitals, Massey Street Children's Hospital, Ethel General Hospital, Onikon Health Center, till he retired in May 2016 and then joined the Sickle Cell Foundation Nigeria. He is the pioneer founder of the Pediatric Sickle Cell Clinic of Ethel General Hospital in 1992 and also the pioneer founder of the Sickle Cell Clinic of Onikon Health Center, Lagos. He's also a trained genetic counselor in sickle cell disorders, and his special interests are care and management of children with the sickle cell disorder. You're welcome once again, Dr. Alakija, to the Inspiration FM studios.
Thank you very much, Thelma.
Good to have you.
Yes.
So today on the show, we're talking about management of crisis in sickle cell.
Yeah.
But before we talk about the management, let's look at some of these complications that actually come with the sickle cell, and then perhaps look at their management, how to manage it.
Okay. Sickle cell disease or disorder, as we prefer to call them, come with different complications, and we must recognize it very early so that we can institute treatment early that will reduce morbidity and possibly mortality also. The commonest is sickle cell bone pain crisis.
Bone pain crisis.
Yeah, that is pain in the bones.
All over the body.
Well, not all over.
Okay.
Sometimes the arm, sometimes the leg, and sometimes even the back, the chest. It can be quite excruciating. In fact, people say that the pain of bone pain crisis is worse than the pain of a woman in labor who wants to deliver. We know what that the woman goes through.
I thought you were going to attribute it to a toothache.
Some
people say that's the greatest
something
of all
like that.
pains. Right.
Yeah, it's quite.
Go
I mean,
ahead.
a little baby. I mean, a little child, for instance, I saw at Onikon Center, 12 years old.
Yeah.
When we came to her, she was folded up in severe pain, and the mother also came in, and she looked at the mother, and you know what she said? She said, "Mommy, why do you bring me into this world to suffer like this?" The mommy was crying. I felt like crying myself. So that we call it bone pain crisis. It affects the different bones of the body.
Okay.
And then again, we can have what we call anemic crisis. In other words, not enough blood in the body.
Yeah.
And the patient is very pale. It's a crisis. Because sometimes you see in the home, they do a little thing, they are tired. They run a bit, they are fatigued. And they can't do many things. And so it's a kind of crisis in which it requires early detection so we can give blood quickly. If we don't give blood quickly, the patient can go off. So those are the two major things we'll probably be talking about.
Okay.
The bone pain crisis and the anemic crisis, severe anemia. But then we have other things like chest pain crisis. We call it acute chest syndrome in our own medical terminology.
Yeah.
That also brings the patient to the hospital. Acute, he can't breathe, he's coughing, there's fever. That's a crisis. If you don't treat it early, the person may die. Another thing that brings patients' crisis to the hospital is what we call stroke. I think we've mentioned that in one of
which
our...
you said a child could pick up as early as 2 years old.
Yeah, 2 years, up from 2 to 16. You know what stroke is. We know it mainly in adults. But children with sickle cell, they come with acute stroke, and it's an emergency.
Okay.
And then we also have cases of what we call priapism.
You mentioned that last week.
I think we mentioned that the way the sexual organ in a man, not a woman, is erected. He doesn't want it, but then just goes erected. And it's not just erected, it's very, very painful. So these are the kind of crises we have in sickle cell disorder.
Okay, so I know that we have in the past weeks, we've gone through a series of complications, but I think that one that we might not have mentioned that I sort of came across and I'd like you to shed a little more light on is the one with gallstones, where they say that there's a substance called the lupin or something like that. Please put me through that.
Yeah, that's another kind of, we call it crisis, but it's complication really.
Okay.
Now, the gallbladder is located in the liver area, and it has the function of taking the bile through the gut system freely. All the excess bilirubin, it goes through them and it goes into the intestine and is excreted. But sometimes, for some unexplained reasons, you find the red blood cells there. They are coagulated there, they are sequestrated there, and they form a kind of stones. And it blocks, obviously, the function of the gallbladder in excreting the bilirubin and so on. And so you find that the bilirubin now sent to spill over into the blood. And so the patient is very, very jaundiced. That's number one. And then number two is that there is pain there. The liver is in the right part of the lower part of the abdomen. The upper part of the abdomen, the right part. That's where the liver is. So when you touch or palpate that area, the patient feels pain and is jaundiced. And then the work of the gallbladder is not doing well. So this is another crisis that can come once in a while, and we know what to do. But you can't manage it at home. Because some mothers will say, when my child is jaundiced, I should give glucose and let him drink a lot of glucose. That's not the cure for gallstones. It's not the cure. Sometimes we may need to do an operation to remove it, and then the function is normalized again. So in cases of pain in the right upper part of the abdomen, mothers must be taught maybe to just feel and palpate it. If the patient is in pain and she's screaming, and there's a lot of jaundice, yellowness of the eye, that is most likely gallstone.
Okay, so what we commonly know, myself and probably lots of people, forgive me if I've been the ignorant one. So when we say jaundice, it's a sort of decoloration of the eyes, where the eyes has sort of like,
Yellow.
It's yellowish.
Okay.
So you're saying that the yellowness of the eye is sort of attributed to a malfunction in the abdominal region. That's what you're saying.
In the case of gallstones. But generally, otherwise, most of the patients with sickle cell, as you know, they have jaundice. It's not because of gallstone.
Yeah.
Gallstone is just one of the many complications. But in the normal case, every child or anybody, in fact, maybe adults too, or children, I'm more in the children's section, any child or adult with jaundice in a sickle cell case, what it means is that the red blood cell is just hemolyzing more than normal at that point. When the red blood cell hemolyzes, let's say it dies and hemolyzes, one of the things that it releases is bilirubin. One of the things it releases is bilirubin. And bilirubin, when it gets so high in the blood, it colors the sclera yellow. In sickle cell disorder, we know that the red blood cell, it doesn't live long. In me and you, the red blood cell lives up to 120 days, which is 4 months, before it dies. But in those with sickle cell, you see, the problem is that the red blood cell is weak. It's not shaped like the normal cell. So it dies quickly. Not up to 120 days, 4 months, maybe 1 month. So many are being destroyed, hemolyzed. They live short, so they are dying quicker. And so more bilirubin is being released quickly than me and you. That the bilirubin is released after the death of the thing in 4 months' time. So that's why they have jaundice. And it's normal with them. I'm not panicky when I see a sickle cell child with jaundice. It's normal. The red blood cell dies about 30 days and it releases bilirubin. And that one goes to the blood and stains the sclera, the mouth, mucosa, and other parts. So it's normal with them. I always assure mother because they are worried. I say it's normal. As long as the child is not sick. It's just that it's hemolyzing quickly. But sometimes something like infection comes in malaria and also bacterial infection, and they now hemolyze more than normal. So when we test the blood level for bilirubin, we see it is more than is expected in a sickle cell child. So that kind of case we need to treat.
Okay. So let's look at the ones that you say are of primary concern.
Yeah.
That's the ones with the bones and then the
Hemolysis anemias
and the
and
anemia.
severe anemia.
Okay. So how do we go about it? How do we manage the bone complication that comes with a lot of pain?
Now, let me say this at the outset. Management of any kind of crisis in a sickle cell is twofold. First fold is the early termination of the crisis. You want to terminate the crisis very early. Because if you don't terminate the crisis, the patient is in pain or whatever it is. So number one is early termination. You terminate the crisis. And number two is the post-crisis management. After the initial one has been terminated, what do you do post-crisis management to make sure that the patient is in a steady state, at least 2 weeks free of symptoms, and it doesn't come back again to crisis? For the painful one, the bone pain crisis. That is a little more frequent one that we see.
Okay.
The patient comes with sudden pain somewhere, extremely acute, and it may not be that he knows what causes it. We don't even know most of the time. The patient just comes in with acute pain somewhere. So the first thing you need to know is that you can manage the patient either at home or in the hospital. It depends on the severity. So if the severity is not too much, you can manage at home. Tell the mother, number one, give some painkiller, paracetamol, ibuprofen, codeine, those kind of things. Let the patient rest. Use some hot fermentation. That is, put towel in hot water, squeeze it, and apply it to those areas where the pain is. Get some diclofenac gel, some of these gels that kills pain. There are many of them in town. So get some gels that is anti-inflammatory and can kill pain. Rub it on that area, and if it's a mild one, you don't need to come to hospital. Within a short time, by the time you repeat this procedure a couple of times, everything subsides.
As a mother, any pain on her child is pain. So how do we know when to say, yes, be careful, this one has passed, be careful? How do we say it again? And you actually do need to see a doctor.
Okay. The mothers can be told that when you see the patient, you yourself can see whether this pain is if she's like still playing around, it's not in chronic folded up position, you might say this is not too much. Okay, the mother can evaluate herself. But if the person is like screaming, is in the bed, is folded up, and is shouting, my mommy, my pain, my leg, that one is not a mild one. So it depends on the reaction of the patient. In the hospital, we have something we evaluate from 0 to 10 in the hospital. 1, 2, 3, 4, 5. We ask the patient to, if I do this, how do you feel? So based on the level of 1 to 10, you can estimate actually how severe the pain is. And when you come, if it's a severe one and the patient comes to hospital, number one is that you need to reassure the mother, because they are full of anxiety. Will my child die? All those kind of things. You need to reassure. In fact, that number one, reassurance, is more important, so to say, or equally important like the real treatment you give. So reassure the mother that, look, it's not life-threatening. It will pass off after some time, and the mind of the mother is settled. Then in the hospital, if it's moderate, if it's severe, the management is different. In the home, like I said, it's mild, just a little thing. But in the hospital, you may need to put the patient on a bed. Number one, you may need to give all these painkillers by way of intramuscular or intravenous. It may not be enough to just give it by mouth. Paracetamol, the pain is very severe. So you need to give it either intramuscular or set up an IV line and give it IV. So that is part of the management. Number two, you need to take blood quickly to see what is happening in the blood. Is it caused by infection? Is it that kind of thing? So if the results shows that there is some infection that has caused it, definitely you need to treat the infection. Definitely you need to give some antibiotics and so on and so forth. Now you need to give things like strong painkillers. If the pain is so severe, you need to give very strong painkillers, because little painkillers may not be sufficient. Even diclofenac that we give may not be sufficient. In that case, you are permitted to give things like morphine, which is considered one of the dangerous drugs. It's permitted in a case of severe pain in a hospital. These are drugs of addiction, and we don't even recommend that people should buy it in a chemist outside. So this, well, you do other things, of course, in the hospital. But the main say is that you must treat the pain. You must treat the infection if there's some infection there. You must set up an IV line, because the patient may not be able to take food, water by mouth because of the severe pain. Sometimes you may need to put on oxygen. Sometimes it's needed sometimes. And so with this, you monitor the patient regularly. And if everything is okay with the bed rest and oxygen and the IV fluid and painkillers and antibiotics if it's necessary, within a few days, most of them get better. But it's unpredictable. You cannot tell the mother in 2 days the patient will go home. Some of them want to tell the doctor, when will you discharge my patient? It depends. Sometimes you do your best, and in 5 days the patient is still in serious pain. So it varies, but you do the best. That's for the pain. For the anemic crisis, the patient comes is fatigued, little effort, is restless. Sometimes they can't even breathe well, and then by the time you check the conjunctiva or actually do a blood test for the hemoglobin level, you see that this patient, the hemoglobin level has fallen seriously. That kind of patient also needs to get admitted to the hospital quickly. That kind of patient also needs to get blood transfusion, because if the PCV or the hemoglobin level is too short, the body cannot function well. In fact, the patient may die if the hemoglobin level falls to a critically low level. So in that kind of case, number one, the patient needs to be admitted. You must do the blood test level and see what is happening.
There's no home treatment for
no
this
home
one.
no home treatment. And that's why we tell mother, once in a while, look at the conjunctiva of your child.
That's the eyes.
The eyes, the lower part. See what's happening there. Occasionally the thing gets white.
Okay.
And if it's getting to pale, it's not red again, it's getting pale, and it's the pallor, the whiteness is severe, you need to rush the patient to the hospital. It means there's not much blood in the body. So that is a very, very important crisis to manage, but in the hospital. And the mainstay of management in that kind of case is not painkiller, because there's no pain in that one. Mind you, no pain involved. Unlike the bone pain crisis, this one is just due to severe hemolysis. The blood is being destroyed very strongly by one thing or the other. And then the blood level goes down, but there's no pain. You don't give any painkiller. You just treat the anemia. You give blood. Blood transfusion is the mainstay.
And there are no particular symptoms. There's nothing for you to actually tell that, blood is actually going down in this particular child, except you check the eye.
Well,
are there things to see?
No, since you have put up an IV line, a blood that is going.
I'm talking about as a parent at home with your child or the person that you live with.
Okay.
Are there symptoms? Are there things that actually?
Oh yeah, like I tell you, the child is very tired. Number one.
Okay.
Is weak. Number two. Any little effort the child does is breathless. Even walking a little distance, the child is fatigued. He slows down. To go one floor, to climb the steps of a room, of a house, one story, he can't. By the time he's halfway, he's breathless. So that's the main important thing, because there's not enough blood in the body, and the child is weak. Any little effort is so mother should take note of that.
Okay. 92.3 Inspiration FM, that's where you're at. It is Surviving Sickle Cell, a show in partnership with the Sickle Cell Foundation of Nigeria and in honor of our beloved Tosi Buckner. My name is Thelma Illems, and I've been doing this with Dr. Tunji Alakija. Management of sickle cell crisis in sickle cell is what we have been talking about, and somehow if you find yourself in such a situation, probably as a caregiver most especially, you can buzz us with your comments or contributions on the number 0700 923 923 923, or you can reach us via WhatsApp platform 0817 313 6193. However, you have said, Dr. Alakija, that you cannot categorically say that there are certain things that actually trigger these crises. But I would love to think that there are things that persons with a sickle cell disorder should actually avoid. For instance, maybe taking too much sugar, maybe not drinking enough water, staying away from smoking, alcohol. We'll find out when we come back from this break. Don't go away, Lagos.
To stay connected to you.
Before 1:30, when we actually step aside on the show. In the meantime, 0700 923 923 923 is the number to call to get through to us. Your calls have been coming in during the break. Let's hope that we can actually pick one or two before we wrap up. Hello, good afternoon.
Hello, good afternoon.
Good afternoon, first caller.
What I will say to the first caller is that why don't you link up with us at the Sickle Cell Foundation?
Okay, so how can he reach the Sickle Cell Foundation?
We are just directly opposite Luth Idiaraba. We will be of great help to you. We will do the best we can do, but reach us, we'll talk and we'll see how we can help you.
All right. Agata, I'm not sure I remember where you said you were calling from. It wasn't quite clear, but the Sickle Cell Foundation, yes, opposite Luth, like Dr. Alakija said, is just at Idiaraba, Surulere, I can say, is in the middle of Lagos. We're taking our last call and then we'll wrap up. Okay. So I guess we really have to go. But before we go, really talking about what triggers, some of these complications and
Now,
crises.
number one, you are talking about whether they should eat this kind of food.
Stay away
What
from certain
actually
things.
triggers it is malnutrition if you're not eating good food. So we tell the patient, eat as much as possible. Carbohydrate, protein, fat, vegetable, everything. When you are in good health, it's not likely you have crisis. Number two is that excess of temperatures, you must avoid it.
Okay.
Too cold and
Too
too
hot.
hot. There was a time we were here, somebody was saying that he or she puts the baby in the sun. And so, no, the sun may be too hot. That can even precipitate a crisis. So too cold, too hot, both of them are not good. Dehydration, if you're not having enough water in your body, that can cause crisis easily. And that's why we ask them to drink plenty water, We ask mothers to tell their children when they are going to school, give them bottled water, at least one or two, to take to school and drink. Because with dehydration, crisis will come. If you are vomiting and stooling, what we call gastroenteritis, you must treat it at home or quickly come to the hospital to prevent dehydration. If there is too much stress, either mental stress or physical stress, imagine somebody running, a sickler, he'll go into crisis. Or somebody that he hasn't been studying in school, and then exam is just 3 days and he wants to read everything. It's up to 10 o'clock in the night, everybody has slept. And he's still reading. And the mother said, Tunji, Tunde, come and sleep now. He said, Mommy, I'm still reading. Within a short time, that child will probably go into crisis. Any kind of infection may precipitate crisis. Bacterial infection, malaria in particular. And that's why we give anti-malaria paludrin, daraprim for them to use. And sometimes we even ask them to sleep on these are mosquito-treated nets. So it's free of charge. You don't need to pay any money for it. Sometimes, again, trauma, injury. If you don't treat trauma and injury very quickly, it can precipitate crisis. So these are the things you should avoid as a sickler.
All right, thank you so much, Dr. Alakija. We appreciate you. Just once again, it has been Surviving Sickle Cell, a show in partnership with the Sickle Cell Foundation Nigeria, located in Idiaraba, Surulere, the heart of Lagos. And yes, in honor of the memory of our beloved Tosi Buckner. My name is Thelma Illems. Let's do this again. Same time next week. That is what? 1 p.m. on Saturday. Bless you and have yourself a wonderful, wonderful weekend. I'll be back.